The title of this talk is Amplitude EEG Interpretation. It will be conducted in a question and answer format. Question 1. The pattern in this frame is most consistent with A. Burst suppression, B. Hypsarrhythmia, C. Tacet alternant, D. Normal sleep. Recall that in a prior video we presented a method of reading amplitude EEG. We will put it to use in this talk. Amplitude EEG is read by epochs. An epoch is a fixed period of time that should be kept constant within a recording but may vary from one study to another. Often institutional protocols or manufacturers' specifications dictate the duration of an epoch. The usual duration of an epoch for amplitude EEG clinical interpretation is 20 to 30 minutes long. The final reading, nevertheless, should incorporate the result of all epochs in the strip provided for interpretation. In this talk, the final reading will be emphasized. The first step in reading amplitude EEG is the evaluation of the strip, compactness. Compactness is evaluated by judging how packed together the individual lines are in the amplitude EEG strip. The verdict must be a binary decision. The tracing is either compact or it is not. In this frame, I enlarge a segment of the strip. You can see that there are areas like here, here, and here where the record is not compact. So we would conclude, judging the 140 minutes recording that is present in this strip, that the strip is not compact. The decision whether the lack of compactness is normal or pathological is done by considering conceptual age. Absence of compactness in a full term is abnormal. Next item to analyze is cycling. To determine the presence or absence of cycling, we trace the upper margin and the lower margin and decide whether cycling is present or absent based on experience. In this case, cycling is absent. Absent cycling in slightly over 2 hours in a full term is usually abnormal. After cycling, we look at bandwidth. First, we look at the lower margin. Traditionally, the lower margin is selected at the transition zone between compactness and scarce regions of the strip, as illustrated in this frame. As you can see, the lower margin is 3 microvolts. The normalcy of lower margin amplitude also relates to conceptual age. At term, the lower limit of normal for the lower margin is 5 microvolts. Hence, in this case, it is abnormal. Now we look for the upper margin and choose it following the same directives as we did for the lower margin. As you can see, the upper margin is about 100 microvolts. An upper margin of 100 microvolts, as you can see in this table published in Neo Review in 2006, at 38-week conceptual age and after, the upper limit of the upper margin in normal full-term neonate is 25 microvolts. Thus, even if we allow double the number before we call the upper limit of the upper margin abnormal, a common approach used in clinical neurophysiology when control values are drawn from a limited number of patients, the upper margin in this strip is abnormal, as stated in this frame. Once bandwidth are analyzed, the next step is to look for sudden narrowing. To do so, we look at the lower margin. There is one at 30 minutes, another one at 70 minutes, and another one at about 140 minutes. Neither the one at 30 minutes, at 70 minutes, nor at 140 minutes show the expected increase in the upper margin that is usually associated with seizures. But often, when the upper margin is too high to begin with, the expected increase in the upper margin that usually accompanies seizures does not occur. So the question of sudden narrowing must be answered affirmatively. And this should prompt looking at the raw EEG, intervening if considered appropriate, and consulting neurology for a formal reading of the raw EEG. This last step should be taken unless the neonatologist is trained to read regular EEG and feels comfortable doing so. The last item we should consider is the presence or absence of artifacts. This implies looking at the strip in question, asking yourself based on your experience if artifacts are present or not. No artifacts are present in this tracing. So how do we put all this together? I think the best way to approach this, putting it together, is using pattern identification. Pattern identification can be either paroxysmal, based on them coming and going in a relatively short amount of time, or sustained, to which I like to refer as background patterns. In this case, paroxysmal patterns were present, which, as you see, consisted of sudden narrowing, consistent with seizures. The background pattern in this strip, as you can see, has abnormal characteristics. It is not compact as it should be at this conceptual age, and the lower margin is too low and the upper margin is too high. These background changes are consistent with burst suppression. The next step is to correlate these findings with conventional EEG and clinical impression. So the answer to this question is A. Next question. The changes indicated by the arrow can be explained by A. Pneumothorax, B. Surfactant administration, C. Phenobarbital infusion, D. All of the above. Starting with the same items as we did to answer the prior question, compactness looks good. Cycling in this 1 hour strip is good. The lower margin is below 5 microvolts. It is actually in the 3 to 4 microvolts range, which in a full term I would consider abnormal. But conceptual age in this case is 35 weeks. As you can see in this table, which I introduced before, in normal neonates 34 to 35 weeks conceptual age, lower margin of 3 microvolts are normal. So we will call the lower margin normal. The upper margin is just about 25 microvolts, which for a 35-week conceptual age is within normal limits. Hence, the upper margin is normal. Next, we consider sudden narrowing. As you can see, they are not present. Then the question is artifact. Here, the word artifact is used in a very inclusive fashion, not only to describe activity not generated by the brain, as it is traditionally done in clinical neurophysiology, but also actively generated by the brain if induced by a known factor, such as an arousal triggered by the family or nursing personnel touching the neonate, or changes induced by medications, or even by known medical events that involve the brain secondarily. This wide definition of the word artifact is likely to change as more information about amplitude EEG becomes available. But at the moment, used in this broad sense, we have to answer yes. Here I have represented the algorithm I used to analyze the overall amplitude tracing. In this case, the background is normal, but there was a paroxysmal drop that required clinical and conventional EEG correlation. Frequent causes of background drops are pneumothorax, surfactant administration, phenobarbital infusion in sick full-term or premature neonates. So the answer to this question is D, all of the above. Next question. The findings in this tracing can be explained by induced hypothermia for the treatment of HIE. A true, B false. This is the protocol for cooling we are currently using at Nicklaus Children's Hospital. The temperature is lower to 33 to 34 degrees Celsius. Temperature produces changes in brain metabolism that translate in EEG changes that are at times detected by amplitude EEG. But with temperature of 33 to 34 degrees Celsius, no significant changes occur. Nevertheless, the time delay required to use failure in background normalization as a prognostic indicator differs in neonates treated with hypothermia from those not treated so. In neonates with hypothermia, only after 48 hours is failure of normalization a bad prognosis indicator. Failure of normalization after 24 hours has poor prognosis in patients not treated with hypothermia. So the answer to this question is B. Next question. This pattern is most consistent with A. Tracé discontinue, B. hypsarrhythmia, C. Tracé alternate, D. normal sleep. This frame has the format that I have used in the past to keep track of amplitude EEG changes. The time span they represent varies according to the ongoing clinical and electrical situation, but usually summarizes about 3 20-minute epochs. I will now incorporate the amplitude EEG strip in this question. Each item will be considered individually. Compactness is normal. Cycling is absent. The lower margin is too high. The upper limits of the lower margin in normal full-term neonate is 8 microvolts, and in this case is close to 20 microvolts. The upper margin is too high. Sudden narrowing are not apparent. Artifacts are not detected. In this case, the background is abnormal. There is no cycling. The lower margin is too high, and so is the upper margin. These findings are consistent with hypsarrhythmia. These findings should prompt a review of conventional EEG. In this case, so was done by the investigator, and they found periods of very high voltage activity and also periods of alternating high and low voltage activity. These periods were not detected in the amplitude EEG since they were very short, lasting about 4 seconds, as you can see in this frame. So, to my already field working in the card, I would add the impression, which is hypsarrhythmia with periods of burst suppression. So the answer to this question is B. Next question. This tracing is A, normal, B, abnormal. In this frame, I have included the tracing and the index card format I use for keeping tracks of changes. The first item to analyze is compactness. As you can see, in the shaded area, the individual lines are not packed together. But at 27-week conceptual age, this degree of lack of compactness is, in my judgment, normal. Cycling in premature neonate is best judged by fluctuation of the upper margin, and again, judgment needs to be used to decide if normal or not. In this case, I would say it is. Absence of fluctuation in the lower margin is common in normal premature neonates before 28 weeks conceptual age, especially when judging only 1 hour of recording. So I would consider the overall cycling to be normal. Lower margin at 27 weeks, as reported in this table from Neo Review, which I have introduced before, indicated here, is normal between 2 and 5 microvolts. So the lower margin is normal. As you can see, the upper margin, if judged by the interface between compactness and sparse region, is around 10 microvolts most of the time. But if judged by the end of the lines, it is close to 100 microvolts. These levels in neonate of this age for the upper margin are acceptable. So the conclusion regarding the upper margin is that it is normal. Sudden narrowing are not present. Artifacts are also not present. Hence, the answer to this question is A. Next question. The prevailing pattern is frequently associated to A. meningitis, B. hydrocephalus, C. stroke, D. genetic epilepsy. In this tracing, you can see sudden narrowing one at the end of the second 20 minutes epoch, and another one in the fifth 20-minute epoch. Here I have enlarged the first area, which has two narrow segments. One here and one here. The second one is followed by a drop in amplitude going from a lower margin of 10 microvolts and an upper margin of about 100 microvolts to a lower margin of 2 microvolts and an upper margin of about 10 microvolts. This pattern is different to other seizure patterns, as you can see in this frame. Here, the seizure is not accompanied by upper margin elevation or postictal depression, as it was in the example I just explained. Here, it is associated with upper margin elevation but no postictal depression. And here, which is the case that we have just looked at, the upper margin elevation is present as well as postictal depression. This pattern, characterized by upper margin elevation and postictal depression, although not pathognomonic, has been associated to genetic epilepsies linked to potassium voltage gated channels, syntactic binding protein 1, and sodium voltage gated gene pathological mutations. So the answer to this question is D. Thank you very much for your attention.